a retrovirus. And there are notes down here should you want that. And this is something that has become very important in medicine over the past 20 or so, 25 years. A disease that was unknown before the late 1970s and is now something that is in the headlines in the newspapers and on television regularly. And that is acquired immunodeficiency syndrome, AIDS. And the reason why I'm talking about it this morning, following on from what I was saying earlier on today and yesterday, is that it's a disease that's caused by a retrovirus. And so the biology of retroviruses that we have just skipped over the surface of is now relevant to this disease of AIDS. As we said yesterday, the number of tumors in the human population that are caused by retroviruses' tumorigenic potential is actually rather small. Only 2 have been discovered, HTLV1 and HTLV2. Cesarean cell leukemia, hairy cell leukemia. But clearly here is a major disease that we know to be caused by a retrovirus. And to understand about this disease, we need to go back to the very beginning of the history of AIDS, and that was back in the late 1970s. And in California, in Los Angeles, in the period prior to the emergence of the AIDS epidemic, there were very few cases of an opportunistic infection that was caused by what was then thought to be a bacterium, Pneumocystis carini. We now know it's actually a fungus. But it was called Pneumocystis pneumonia. And it was a very rare disease that you saw in very severely immunocompromised patients. Very rare. But in 1979 in Los Angeles, CDC got the data together and reported 5 cases of this in 1 year. Clearly, a big increase in the incidence of still a rare disease. And they all were in the homosexual population, the male homosexual population. We now know, as I said, this is actually caused by a fungus. You can see it's in this cell here, these little dotty things. And it's now known as Pneumocystis jirovecii. And Dr. DeSalvo will mention this again when he comes to talk about mycology. But here we have a rare disease of immunocompromisation that's coming up in a particular community with a particular lifestyle. Prior to the AIDS epidemic, they looked at the figures, 107 cases of this Pneumocystis pneumonia were recorded. Since the AIDS epidemic started, 166,000 cases of this formerly rare disease. And it's not only a pneumonia, it can spread to other parts of the body, causing things like calcification here in the kidneys. Another disease came up at about the same time, Kaposi's sarcoma. Again, from Mortality and Morbidity Weekly Report from the CDC, early 1981, 5 cases were found in a certain community on the West Coast in San Francisco. This is a disease which causes endothelial cell proliferation. We know now that it's caused by a herpes virus, and I mentioned that to you yesterday. It was, up until the AIDS epidemic, a disease that was found in elderly people, people who were losing maybe the robust immune system, elderly men particularly elderly Jewish men of Mediterranean ancestry. And it was really quite an indolent tumor. The people who got this very often died of something else. A benign sort of tumor. Not aggressive, at least. And in 1981, 26 cases in San Francisco and New York of a more virulent, aggressive form of Kaposi's sarcoma appeared in the young male homosexual community of these 2 big cities. Another disease of immunocompromisation. Before 1981, 40 or so cases per year in the US. in elderly males primarily. After the AIDS epidemic, there have been 46,000 or more cases of Kaposi's sarcoma. Two rare diseases in a particular community associated with immunosuppression and opportunistic infections. You don't die of AIDS as a result of HIV. You die of the opportunistic infections that are the consequence of HIV. Other diseases of immunosuppression, lymphadenopathy, non-Hodgkin's, no cases in the San Francisco area between 1977 and 1980. In this period here of less than a year, 4 cases in 10 months. And so was born a disease that was known originally as gay-related immune deficiency, GRID. Today we know it as acquired immunity deficiency syndrome, AIDS. Little in common amongst the people who got this disease, except they were young, they were white, they were male, they lived in large towns like New York and San Francisco, and they were part of the homosexual community. But not all people with that lifestyle actually got the disease. There were some distinguishing contacts. They were in clusters. Very often somebody who was suffering from this disease knew somebody else who was suffering from the disease. Particularly, these clusters were within sexually interactive groups. The people who had a bigger predisposition to going down with this disease were the people who were more sexually active. And that then gave rise to the idea that this has to be an infectious disease. And clearly, it's a sexually transmitted disease. More evidence came from subsequent ways you could get AIDS: by blood transfusions, by intravenous drug use, by the use of clotting factor if you had hemophilia, and also the female sex partners of AIDS patients acquired the disease. So there was nothing about being male here that was important. And now the disease is no longer restricted, as it was originally, to the gay community. Also, another factor that seemed to predispose you to getting this disease in the United States was if you were of Haitian origin. But in this community, homosexual activity was not reported. So, although these people were primarily males of Haitian origin, that was because most of the immigrants into New York and places like that tended at that stage at least, to be male, in terms of at least Haitian immigrants. But back in the island of Haiti, it was clearly not a homosexual disease, and most people who had HIV or who had AIDS, who were of Haitian origin, did not report any kind of gay lifestyle. So by 1983, MMWR was referring to the 4-H club, and this was homosexuality amongst males, hemophilia because you acquired whatever was causing the disease via blood transfusions or by clotting factor, heroin use by the use of shared needles, and of Haitian origin. And clearly it's a virus. People were assuming that what's happened now is that there's a virus in the blood supply, but it is primarily transmitted by sex. But if you transfuse blood from one person to another who's infected by this virus, then that person pretty certainly goes down with HIV-infected disease, or at least AIDS. HIV had not been discovered by this stage. Sexually transmitted disease. And when we look at the cellular picture, we have more evidence for this being a virally transmitted disease, because what we can see why the patients are becoming immunocompromised, because they're losing one particular cell of importance in the immune system, the CD4-T4 helper cell. And the loss of those cells always precedes the overt manifestation of immunocompromisation and disease. In advanced disease, the CD8 cells go as well. And again, this suggests a virus. The particular tropism for one kind of cell in the body is indicative that what we're dealing here with is a virus. But it was a virus that turned out to be extremely difficult to grow for reasons at that stage were unknown. But when people took samples of blood from these patients and tried to grow out a virus, they couldn't do it. Now we know the reason for that. The virus only grows in activated T4 cells, CD4 positive T4 cells. They didn't know that at the time. They found great difficulty in growing it. Clearly, though, when it does grow, when the CD4 cell gets activated, the virus grows and the cell dies. So, what is AIDS then? Well, currently AIDS is defined by the CDC and by the World Health Organization as defined as the presence of one of 25 conditions indicative of severe immunocompromisation or an infection in which the individual has a CD4 positive cell count of less than 200 cells per cubic millimeter of blood. There's a slightly different definition of pediatric AIDS in which the 25 conditions actually expanded, I think, by 2. If you want to know what those conditions are, I don't remember them. I don't expect you to remember them. Go to the website. I've got a listing there of the conditions that are used in the definition of AIDS in one of your patients. So AIDS is the endpoint of an infection by a retrovirus, by a virus at least at this stage, that is progressive and obviously pathogenic. And it's with us for a good few generations to come. Looking at the statistics, there are about 44 million people in the world that are HIV infected. We're getting 14,000 new infections every day. Most of these are in developing countries. Some of them are children. And now about half of them are women. And in certain sub-Saharan African countries, women have now achieved the dubious status of being in the majority as far as HIV infections are concerned. With the United States, about 1 million people have been reported with the AIDS disease. Half of them or so have died. There are about 9,000 children have been reported with AIDS. And there are probably about 1 million people who are now living with an HIV or AIDS in the United States at this present time. It's not going away. In fact, because we have better ways of ameliorating the consequences of the infection, better ways of treating opportunistic infections, better ways in reducing the number of virus particles that leads to the destruction of the immune system and therefore the consequent immunosuppression, because we've now got better ways of treating the disease, there are more people who are surviving, therefore there are more people who are in AIDS infected, HIV infected, and therefore there are more people who are potential infectors of other people. So we've done nothing about getting rid of the infectious agent. We have no vaccine or anything like that. We have had enormous success, however, in treating the patients who have been infected and stopping them dying. But by stopping them dying, we have more potential vectors. You can see how AIDS had an effect on health in this country. These are the rates of death from certain diseases in the 25 to 44-year-old community in the United States. Things like heart disease, cancer, homicide, chronic liver disease, stroke. And you can see here, in this community, AIDS became the most important cause of death in younger people during this period. Now, as a result of better treatments and things, that has fallen off. But that is death. Infection still continues to rise. Here's the prevalence of the virus in the community. It's going up inexorably. However, if we look at deaths, they've fallen off, and actual overt AIDS disease has fallen off, because we now have this highly active antiretroviral treatment, HAART, that allows us to keep the virus down. Originally, a white, male, gay disease, now clearly in other populations in the United States, and the number of cases is actually higher now in the African American community compared to the Caucasian community. Sub-Saharan Africa, where most people don't get any treatment at all for this infection, the situation is dire. 1 million new cases every year, 30 million or so people infected, a decrease in life expectancy. And we can already see that. Whole generation is getting wiped out by the presence of this disease. Several sub-Saharan African countries, over 25% of the people in towns are infected by HIV. 30% of the adult population of Zimbabwe are infected. 90% of truck drivers Truck drivers go on long routes, tend to patronize prostitutes, spread the disease along those routes. You can see that in India, along the trunk roads. AIDS spreads along the trunk roads, carried by truck drivers. 1 in 5 girls in urban areas in Zambia infected by HIV. And this shows from the World Health Organization the life expectancy in certain sub-Saharan African countries. One bright spot, Uganda, promotion of habits, that particularly condom use, that been very widespread in Uganda, and as a result, there's been an uptick in life expectancy in Uganda. But for other countries still, it's still a big problem for every country, but there's been a little bit of ray of hope here in Uganda. So obviously then, here is a disease of immunocompromisation that is caused by a virus. And that virus is well known today, and here it is. It looks like a retrovirus. It is a retrovirus. Doesn't look particularly nasty, but clearly it is. And as I said, the clue to identifying the agent that causes this disease was our ability to grow it in the laboratory. And that was the recognition that this virus proliferates only on proliferating CD4 positive cells, activated CD4 positive cells. And so when they recognized that, they used the assay for reverse transcriptase and found that these cells were reverse transcriptase positive, indicative of infection by a retrovirus. 2 people who were most important in the discovery of HIV were Robert Gallo, then at the National Institutes of Health. And he was the guy also, his laboratory discovered the other 2 retroviruses involved in cellular proliferation control, HTLV1, HTLV2, so he called this HTLV3. At the same time, Luc Montagnier at the Pasteur Institute in Paris discovered a virus that he called lymphadenopathy virus, LAV. They're now known to be the same, and so it's now known as HIV. Now, when we look at the patient that is infected by this, we see soon after you're infected, up goes the amount of virus that you can assay in the patient's bloodstream. Antibody comes up rather later. The virus is already going down before the antibodies start to come up. We think that this primary defense against HIV is a cell-mediated response. But look at the CD4 cells here. They jiggle around. Even though the virus goes down to this set point here, the CD4 cells jiggle around, and inexorably they go down over the lifespan that remains for the patient. And when they get down to a low level, the cells, the immune system can no longer control the virus, and then it starts to come up here. CD8 cells tend to stay around. In fact, they go up at the very beginning of the infection, and then they crash. So let's look a little bit more at these stages in the natural history of HIV. Start off at the very beginning. You get HIV. Primary route, you're going to get it by sex. You're receiving some kind of sexual secretions, sperm or vaginal secretions. Macrophages are in that. Those macrophages are the primary transmission agent of HIV from one person to another as a result of sexual activity. Very rapidly, as you saw in my diagram up here, you get a high virus titer detectable in the blood. You measure this now by PCR. Mild symptoms, if any. Flu-like. Mononucleosis-like. Headaches, bit fever, myalgia. Just a feeling of malaise for a short while. Nothing to get worried about. We've all had that. CD4 cells, as I showed you, go down a little bit, but then they recover. CD8 cells go up a bit, but they come down to normal levels. High virus titer in the blood, though. Here. And it's the macrophages at this stage. If you've got it by sex, that's the way you've got it, through the macrophages. So at this stage, it's the macrophages that are important. And you get a strong immune response as a result to the virus. That's not true that we don't make a very good immune response against HIV. We make a really very good response to HIV. We actually bring the virus load down enormously. But it doesn't get rid of the virus completely. So we get a good cytotoxic T-cell response. We see soluble antibodies coming up. And the virus is now spread into the CD4 positive cells. But you're going along quite nicely. You've got over that initial flu-like symptoms. You're going along quite nicely. You're infectious. You don't know it, because you've been tested for it. Because your CD4 cell levels are compensating. You're making more CD4 cells as the other ones are dying. And you go into a latent state, a clinically latent state. The virus persists now. You've got this set point here of virus in the bloodstream, but it's elsewhere in the body. It's in extravascular tissues. The dendritic cells are important here, because the dendritic cells all over the body are encountering HIV. They bind it. They don't internalize it, because they don't have the correct receptor to internalize it, but they can bind it. And they nip off to the lymph nodes and things involved in antigen presentation. And they come along to the other cells of the immune system. They say, here you are. And they present this nasty virus to the other cells in the immune system. They concentrate the virus into the lymph nodes. And the cells of the immune system, of course, are going through these lymph nodes, etc. And the virus takes up residence in CD4 cells, and in particularly important in the memory CD4 cells. These are the CD4 cells that after an immune response are going back and resulting in immune memory. The virus is not replicating in these cells because these cells aren't dividing. But it's there as a provirus. And when they get activated again, as we'll see in a moment, up comes the virus. And that is a big problem. But during this set period, during clinical latency, you're producing quite a lot of particles of virus. They're not very long-lived. There's a set point that your patient will achieve of keeping the virus down. Some people will be better than others. Some people will have 100 or so, this is in the absence of any treatment, 100 or so virions per mil of blood. Some people will have millions. But there's this sort of level that you maintain through this latent period. And at this stage, you can see that the minority, a very small minority actually of CD4 positive cells are actually infected because the ones that are dying off are being replaced by new CD4 positive cells. And you're finding the virus particularly concentrated in the lymph node in association with those dendritic cells. And then disease starts to occur. And as I've said, what the patient dies of is not the infection. The patient dies of a secondary infection as a result of the fact that that secondary infection cannot be fought off. And you get the beginnings of disease as a result of the crash now in the levels of CD4 positive cells, because they are the targets of the virus. So the cells that are actually proliferating to respond to this infection get killed off by the virus. The dendritic cells are still there, stupidly presenting the virus to the CD4 positive cells. This is a retrovirus which is constantly mutating. So you're fighting off with a darn good immune response only to have the virus change its proteins, antigenic proteins, and escaping the immune response. Epitope variation. Also, unfortunately, your non-infected CD4 positive cells turn around and commit suicide. They undergo apoptosis, which exacerbates the problem. Now, if you're lucky enough to maintain your CD4 positive cells, and certain patients do, you don't go down with AIDS. You don't get immunocompromisation, irrespective of whether you have a HIV infection or not. It is the loss of the T4 cells that cause you to be immune compromised. If you manage to keep your T4 level up, you're okay. And here's a dendritic cell here, happily embracing a CD4 cell, a lymphocyte. And if that was carrying HIV around, And you can see the intimate contact of these two cells results in the transfer of the virus to a cell that can replicate the virus. And as a result, now we get advanced disease. CD8 cells started to get rid of the CD4 cells. No longer can you control your infections. The immune response collapses. The CD8 number collapses. And without intervention, death inevitably occurs within 2 years. And that would be a good place to take a break.